Hello, everyone, and thank you for joining our webinar today with Dr. Susan Noonan. Dr. Noonan is a physician, patient, and author. She is also a writer for the Psychology Today blog on managing depression and bipolar disorder, where she draws on personal experience and evidence-based medical information to create practical guidelines for managing and caring for someone with those conditions. She currently works as a consultant and peer-certified specialist facilitating groups in the greater Boston area. Dr. Noonan obtained her medical degree at Tufts University School of Medicine, an AB from Mount Holyoke College, and a master's degree in public health from Harvard University School of Public Health. She achieved board certification in emergency medicine, which gave her the opportunity to treat patients with a variety of medical conditions, including many years counseling, treating, and advocating for individuals with mental illness. Today, she will be sharing tips for families of those who have bipolar disorder. Welcome, Dr. Noonan. It's a pleasure to have you with us.
Well, thank you very much. It's a pleasure to be here and quite an honor to be invited by the International Bipolar Foundation to give this webinar. I also want to thank the audience for joining us today. I've been asked to speak with you about how close friends and family members can help someone who has depression or bipolar disorder. That's the topic of my recent book called When Someone You Know Has Depression, Words to Say and Things to Do. So during this presentation, I want you to keep your questions in mind because there'll be time for question and answers at the end of this. Now, two questions first. What is bipolar disorder and why should you listen to me? Well, the way I like to think about it is, bipolar disorder is a common, biologically based illness of the mind and body that affects the thoughts, feelings, actions, and everyday lives of many people. It can be defined as episodes of depression alternating with episodes of elevated mood. Worldwide, it affects about 51 million people, including about 5.5 million adults and up to 1 million children and adolescents in the United States alone. A person who has bipolar disorder experiences intense, periodic shifts in moods called episodes. He or she usually has episodes of the sad, low moods of depression, alternating with high energy states called mania or hypomania. The length of each episode and the time in between varies with each person. The symptoms of bipolar disorder come and go in an unpredictable pattern that's unique to each individual. Many people first have an episode of depression before they experience any manic or hypomanic states. These often begin around the age of 18 or 20, although bipolar disorder has been seen in some children and older adults. The fluctuation in your family's members' illness may make it tough to predict what each day will be like. These mood changes can be very frustrating to watch, live with, and know how to handle. Mood disorders such as depression and bipolar disorder are often considered family illnesses, and that's for two main reasons. First, they can be genetic or run in families. It's been reported that more than 2/3 of those who have bipolar disorder have at least one relative who has either bipolar disorder or unipolar major depression. This suggests that there may be an inherited component. Researchers have recently begun to identify genes associated with both depression and bipolar disorder. A gene is a sequence of DNA, which are molecules. It's part of a chromosome inside each of our cells, and it's inherited from our parents. While a person can inherit genes that make him or her more likely to experience a mood disorder, it doesn't guarantee that it'll have the illness, He may not have an episode unless he also has certain stressful life events during a vulnerable period in his life, during the time when the genes affect brain functioning. The second reason bipolar disorder is considered a family illness is that it usually has an impact on the surrounding people like you as well. Family members and close friends feel the mood shifts and stress of living in the household of someone who has this illness. They also play an important role and are often the first ones to recognize the subtle changes characteristic of bipolar mania or depression. So you, the parents, spouses, partners, siblings, friends, need to know what to say or do and not say when their loved one has impaired thinking. That's why I wrote my book, as a practical guide for you who are struggling to do the right thing. So now, why should you listen to me? Well, I bridge that space between recipient and provider of healthcare services, and that gives me a very unique perspective. I'm a patient with a long personal history of depression on the bipolar spectrum, an author of 2 books, as well as a blog on depression and mood disorders. I'm a certified peer specialist and a physician. I can speak from firsthand experience, backed by medical evidence, about what things are like and what really helps. I had my first episodes of depression as a teenager, then again in my 20s and 30s and 40s. But all of that went untreated until I reached the age of about 45. It just wasn't done, at least not in my family. And that's the case for a lot of families. We just didn't speak of it. But then at the age of 45, I had an incapacitating episode of depression where I couldn't function, work, think, concentrate, sleep, or eat. And then I received treatment. And since then, I had more than 40 well-considered medication trials, lots of hospitalizations, like psychotherapy, a course of ACT, and I participated in a clinical trial for 10 years studying the use of a vagus nerve stimulator implant for depression. It took a very long time and extraordinary perseverance on my part to not give up, but eventually, after many years, we found the best treatment formula for me. I improved, and I learned how to manage the illness with continued treatment. I have an awesome treatment team who held hope for me when I was scraping bottom and I had absolutely none. I learned it's interesting to compare the different kinds of support that you get in life. When you have depression or bipolar disorder, people rarely call. There are no rides offered, and nobody brings chicken soup for a mood disorder. Friends and family respond differently to you when you have cancer or a broken bone versus a mental illness. This is a really important point for you to remember. Even the very same loving, caring, highly educated people react differently without meaning to. It's not really their fault. Maybe family members or friends are fearful or feel awkward speaking of mental health issues. I don't know. I do know that for me, there was a closer interpersonal connection, greater support, more phone calls and visits and concern when I was treated for other things than for my mental illness. Now then, where do you find bipolar disorder? Well, you see it in your family members, in your friends, your neighbors, your coworkers, and people you'd never suspect because most folks don't want to talk about their illness. So, what should you look for? Well, there's a set of guidelines that are created by the American Psychiatric Association and published in a book called the DSM-5. These are used to diagnose mental health conditions, including bipolar depression and mania or hypomania. For bipolar depression, you need to have 5 of the following 9 symptoms that persist for 2 weeks or longer. And they need to include at least one of the first 2 to make the diagnosis. So what are these symptoms? They include a really sad, depressed, or irritable feelings during most of the day, loss of interest or pleasure in things that used to bring the person some fun and interest, sleep changes, too much, too little, or fragmented sleep, unintentional weight gain or weight loss, loss of energy, decreased ability to think, focus, concentrate, and that includes reading and watching TV. Physical restlessness or a sense of being physically slowed down. A sense of worthlessness, hopelessness, guilt. And this includes negative thoughts and thought distortions, what we call cognitive distortions. And the last is thoughts of death and suicide. Now, for bipolar mania or hypomania, the DSM criteria to diagnose them, a person needs to experience an elevated or irritable mood that impairs functioning for at least 1 week, plus 3 or more of the following on this list, and that includes an elevated or euphoric mood, a sense of grandiosity, a person being full of great and grand ideas, fast and racing thoughts. You might notice that they have increased physical activity and mental activity. Their just thinking is just racing around and very fast, or they appear very agitated. There's a decreased need for sleep. It's not just that they don't sleep and then feel tired the next day. They just don't feel they need to sleep. Distractibility with poor concentration. A certain way of being more talkative than usual, which is called pressured speech. Irritability. And high-risk behaviors, such as excessive spending, impulsive sexual behavior, fast driving, the use of street drugs, and excessive alcohol use. Now, how does that translate to your family member? You might see a person who stops caring about himself and his life or his world, who no longer participates in his treatment, has lost the flavor for life, prior activities, and the people around him. You might see marked changes in appearance, in his or her dress, hair, hygiene. They stop washing and showering. Changes in sleep, appetite, weight, friends at work or school, performance at work or school. They may be socially isolated and very withdrawn. You might find your loved one to be particularly irritable and argumentative. He or she may be very fatigued, or if on the other end of the spectrum, may be highly energized, elated, and euphoric. You may have negative and distorted thoughts and feelings, or may have racing thoughts, may be more talkative than usual, full of grand ideas, and exhibit the high-risk behaviors I just mentioned. Now, it may seem difficult to keep track of all these things, and it probably feels overwhelming to you. You might be wondering right now, where do I begin? Well, the first thing to do is to provide support to your family member who has bipolar disorder. Support involves time spent listening, hearing, and acknowledging the emotions he or she is experiencing without judging. You want to just be there and let him or her know that you're in this together. Each person has her own way of communicating distress and accepting help. Some people are more private, some more talkative, some more active. Attempt to understand your family member's unique style, reactions, and openness to receiving your help, and then base your approach on that. Try to be patient with him or her. Remember that bipolar-related thoughts and behaviors may not make sense to you, but they're not intentional. Listening is an art. It takes time to get really good at it. So here are a few tips to get you started. Begin by making yourself available consistently, setting aside a regular time and private place to check in with your family member and find out how he or she is doing. Talking about it won't make things worse. Accept what he has to say in confidence and don't repeat anything you've heard. Allow him time to speak openly without interruption and understand that he may not always be able to talk about his feelings at any given moment or share what was discussed in therapy. Show that you've heard what he has said. One way to do this is by using open body language. This means that you sit down, make direct eye contact, use a clear, calm, neutral voice, turn your body towards your family member, relax your arms and body, give him your full attention, and turn off your cell phone. That's far more effective than standing over him, looking down on the person, crossing your arms or pointing your finger in judgment, or appearing distracted or disinterested. Now, during the conversation, if your mind wanders, which it will, just bring it back to the topic. Show that you're fully present and interested by nodding your head or saying, periodically. Ask open-ended questions to draw him out, such as, how did that make you feel? Or, what do you think would happen if? That's much more effective than a question requiring a simple yes/no answer. Show that you've heard him. You can do this by repeating his exact words, by paraphrasing, or by reflecting on what he just said. This is important because it communicates that you understood what the person has just said and validates his thoughts and feelings. Try to tolerate short periods of silence. This may happen if her feelings are very intense or she's deep in thought. It gives her permission to feel or express her emotions. After a few minutes, you might ask, what were you thinking of just now? Avoid cliches like, snap out of it, pull yourself together, if only you would do this or that, or my personal favorite, hang in there. They don't communicate anything meaningful and are perceived as being dismissive. Try to provide a sense of hope and keep realistic expectations for your family member. This has to be a genuine effort on your part, backed by solid information that you get from your family doctor or reliable sources. For example, be supportive if he or she needs to scale back or take a temporary leave of absence from work or school. That's not the worst thing in the world, and it won't markedly damage her overall life. It's often helpful to communicate in a sincere, believable way things like, "This is a real medical illness. It's not your fault." Or, "I'm here with you. How can I help?" Or, "You are not your illness. You are a," and then talk about whatever concrete, real skills the person may have. Um, you're a fun, loving daughter who's good at soccer and caring to her cousins or children she babysits for, whatever it is that applies to the person. And that's real, not something you made up or glossed over. It's also important that you be clear and consistent in what you can and cannot offer in support, that you set clear limits and expectations for both you and your family member, and that you try not to promise anything you cannot deliver. Treat your loved one normally and include them in usual everyday activities and family and social plans. Expect that he'll take out the trash or she'll do the dinner dishes and join you on family social activities. Learning as much as you can about the illness and the treatment options from reliable sources you'll find to be quite valuable. It will come in very handy to help you understand the illness and for you to better help your family member manage it. If your family member has had more than one episode of bipolar depression or mania in her life, try not to assume that she'll automatically know how to handle the next one. Illness memory is a funny thing. And in bipolar disorder, it's hard to focus and concentrate on the details from past episodes. She may even deny having felt this way before. Now, another thing that really helps is for you to encourage the basics of mental health, which are essentially the same as the basics of health. You might even be the role model for this by doing some of these things yourself. So what are they? Well, they include the following. First, to treat any underlying physical illness the person may have. The next is to follow sleep hygiene guidelines. Sleep hygiene is a set of guidelines developed by the American Academy of Sleep Medicine to help promote restorative sleep. They're available online, and or in my book, for example, and they include such things as going to bed and waking up at the same time 7 days a week. There's no such thing as catching up on sleep on the weekends. To reserve the bedroom for sleep and not to do work, play video games, watch TV, eat meals, things like that, to keep the bedroom a calm, cool, and quiet place to promote sleep. There's a whole set of guidelines for that, and following some of those would be helpful. The next of the basics is to follow a balanced, healthy diet and nutrition. Now, one example of this is something called the Mediterranean diet. That's also available online. That includes things such as eating lots of fruits, vegetables, lean meat and fish, minimal amounts of fats in the form of oil, such as olive oil, avocado, a few nuts, limited dairy. It's a very healthy diet. Next is to take medications as prescribed and avoid the use of street drugs, alcohol, tobacco, excess caffeine, and use herbal supplements only on the advice of a physician. You want to get daily physical exercise that includes both aerobic, strength, stretch, and some relaxation or meditation thrown in there. Very important for someone with bipolar disorder is to have a daily routine and structure. Empty hours of endless alone time are not healthy for anybody. The next point is to avoid isolation. Isolation is intentional withdrawal from activities in one's daily life and the people around them. It's different from solitude. Solitude is a choice, a purposeful time for self-reflection, relaxation, and a time to replenish oneself. And that's okay to make time in one's life for that. It's not isolation, not the same as isolation. And the final point is to keep up with regular social contacts and social support. Now, for you to think about helping someone who has a mood disorder is different and feels different from caring for a person with other medical problems in several ways. It carries with it some special challenges, and they include, first, turning down offers of help. Caregivers might find that a person who has bipolar disorder rejects offers of help rather than welcomes it. You might be familiar with the phrases, "leave me alone, you just don't understand." It's not by choice, but rather because the illness affects one's mind and ways of thinking, and it requires a lot of patience on your part. The next challenge has to do with stigma and misunderstanding. Stigma is unfounded negative judgment and criticism based on misinformation. It's an unfair label placed upon a person who has bipolar disorder. It can come from school friends, family members, images on TV or the media. If believed, it can lead someone to wonder whether the person really has an illness after all, or to think she's not really trying hard enough to get better. And these thoughts can happen even if you're knowledgeable about the disorder and have the best intentions, and particularly when you're really tired and stressed out. So try to be aware of these thoughts. Recognize they're not helpful and only contribute to the stress of caring for your loved one. The third challenge surrounds the confidentiality and sharing of medical information. In this country, the privacy of medical information is strictly protected by federal regulations. This makes it difficult for you to speak in detail or share information with your family member's treatment team. So you may feel shut out from evaluation and treatment decisions. But in an emergency, you can contribute valuable information without violating privacy concerns. The fourth challenge has to do with the uncertain outcome of some psychiatric treatments. We're familiar with the expected guidelines and treatment outcomes for many medical problems, like a strep throat or a knee replacement. We usually know how to take antibiotics for 5 days or 10 days for a strep infection. We know that following knee surgery, you stay in the hospital for a few days, then go to rehab, then home with continued physical therapy. But it's much harder to predict treatments and outcomes for mood disorders. Some people who have bipolar disorder, depression, or mania respond to the first treatment. Some, like me, require many medication or therapy trials before they even see a response and begin to feel like themselves again. It's very difficult to predict for even the most experienced physicians. And lastly, there's a lack of established routines for caregivers such as you. We all usually know how to respond to a heart attack victim or a cancer diagnosis. We know how to dial 911 in an emergency, when to bring casseroles and funny movies, and do fundraising walks for other medical conditions. But family and friends who provide support are still not quite comfortable in knowing just what to say and do for a person who has a mood disorder. How best to help. Now, another problem you may encounter is when someone refuses to get treatment, and that may place you in a very difficult position. It's a situation where you cannot force treatment if she is over the age of 18, unless she's at the risk of harming herself or someone else, or shows signs of psychotic thinking. Psychotic thinking is a type of impaired thinking where the person is removed from reality, where she sees or hears things that are not there. But it's not very common. So, when someone refuses treatment, one approach is to first reinforce your love and concern and that you're there for her. You might begin by spelling out what you observe in her that's different from her usual baseline self, such as changes in appearance, level of energy or fatigue, lack of interest in previously enjoyed people or activities, changes in sleep or appetite, or negative feelings or thoughts noted in conversation. Try to provide clear information on treatment that you've learned from your family doctor or read about from reliable sources. And one great resource is the book Healthy Living with Bipolar Disorder, provided through the International Bipolar Foundation. Offer to help with the fine details of getting help, which can sometimes feel overwhelming. This could include providing phone numbers for mental health professionals in her area or driving her to an appointment. Try to understand what's behind his or her reasons for refusing treatment and address those issues. Someone may refuse to accept treatment for many reasons. He may believe it indicates he's a failure. It may make him feel more vulnerable and that it's intrusive. She may be concerned about financial issues in paying for treatment, or privacy issues and fear of stigma if friends or coworkers found out. He may believe that treatment is not effective, at least not for him. A person may fear becoming dependent on medications, or may dread the side effects he's heard rumors of. He may be concerned that treatment such as talk therapy may raise up strong emotions inside that he fears then having to deal with. If you can understand his or her reasons for refusing treatment, this may open the door for discussion on treatment options. In some situations, you might have to set boundaries, particularly if you're dealing with an adolescent or a teenager. And that includes both of you accepting agreed upon acceptable behaviors. Sometimes a tough love approach is necessary and effective. You might have to take away certain privileges from a teenager, like the keys to the car, until such time as he or she shows that she can care for herself safely by taking her meds, attending and participating in appointments, complying with treatment plan, not drinking and driving, things like that. Sometimes you might find your loved one expressing thoughts of not wanting to be around, thoughts of suicide, or you might notice some of the warning signs as seen here. He or she might talk about suicide or have a plan or just refer to it in more subtle ways, such as be a burden to others, or you might be better off without him around, or she might say she just doesn't want to be around anymore. There might be increased use of alcohol or street drugs, reckless and high-risk behaviors. There may be withdrawal from activities and their previous life with a lot of isolation. He or she may begin to give away some prized possessions, their favorite objects. They may appear depressed and anxious to you, with a loss of interest in their activities, or anger, rage, and irritability. And in some cases, they may seem to experience humiliation. That could happen if they've been publicly exposed for something that they feel they're responsible for, even if that's not the case. If any of these warning signs happen, don't be afraid to ask about it. It won't encourage him to take action. It can be a scary and uncomfortable conversation for you to have. You might say something like, "I've been very concerned about you lately. Are you wishing you weren't here or thinking of harming yourself? Do you have a plan? What is it?" Gently but firmly press for the details and be specific. Do your best to listen. Let him know he is not alone. Suicide is usually considered an impulsive act and a troubled person who sees no way to challenge his painful circumstances. He sees no way out. Suicidal thoughts and behaviors of any kind are considered a psychiatric emergency and require immediate attention. It's one of the greatest tragedies and complications of mood disorders and claims about 41,000 lives a year in the United States alone. Teenagers and young adults are at risk for suicide, in part because of the stress to succeed and pressure to fit in with their peers. Older people are at risk as they face loneliness, loss of friends and family, physical impairments that limit their lifestyle, medical problems, chronic pain, or loss of independence and purpose. Your best approach is to see that your family member received effective medical care for his mental or physical illness or substance abuse, with a combination of both medical and mental health treatments. Go through the house and make sure he has no access to lethal means of suicide. Remove all pills, firearms, knives, ropes. Provide him with support and a strong connection to you, friends and family, and his community. That makes a difference. Be very ready to call 911 or bring him to your local emergency department if necessary. And lastly, don't forget to take care of yourself. You as a caregiver cannot be of help to anyone else if you're burned out. Mental illness in the family can be rough on a family, particularly the primary caregiver. The fluctuating moods of someone who has bipolar disorder can add to the stress of a busy household and affect everyone around him. You may also have many emotions yourself, such as frustration, anger, or guilt, and be physically and mentally fatigued. You must be careful to attend to your own and other family members' needs to avoid burnout. Take the time to get enough sleep, eat well, get regular exercise, relax, stay organized, keep up with your own pleasurable hobbies, social activities, and friends. Go to a concert or a movie. Get a haircut or a manicure. Go shopping. Tend to your garden or workshop. Continue to do whatever little things in your day that bring you pleasure. Don't cancel them. Your family member will thank you for your efforts. And I thank you for your time today. I hope this presentation has given you an understanding of the illness, ideas for effective things you can say or do, and how to better help your loved one. I wish you continued health and success. Please consider contributing to the International Bipolar Foundation to enable the continued educational programs, lectures, and webinars such as this. Your generosity is most appreciated. And now we have time for some questions.
Yes, thank you very much, Dr. Noonan. We will now begin the question and answer portion. Feel free to continue to submit your questions while we begin the Q&A. All right. Dr. Noonan, the first question.
Yes.
What or whom does your care team consist of?
My own personal care team consists of actually 2 psychiatrists who have a different slant on things, and a psychologist, and my primary care physician.
Great, thank you for that. The next question. What do you say to your loved one when they say unrealistic things during a bipolar episode? Sometimes it seems listening is not enough.
That's a very good question. And it's hard sometimes to hear things because you can understand that it's not the person talking, it's the illness. And so you might want to try to communicate that. You can try to say something like, I hear that you feel that way right now, or you're experiencing that thought or that feeling right now, but I can remember a time when you didn't feel that way and when your thoughts brought you elsewhere. So let's please pause for a moment and perhaps think that the illness is helping to change your thinking in ways that you're not as aware of as those of us who love you can see. Something like that might help.
Okay, great. The next question is, I am an individual with bipolar disorder, and I feel invalidated when I'm asked, have you taken your meds, when it's apparent that I might be manic. How can I, as the person with bipolar disorder, respond to that when I have indeed taken my meds and I am feeling invalidated?
That's a great question. Part of that comes, part of the answer to that makes me think of who is asking that question um, in your life. Is it someone in your immediate circle, like your spouse or your significant other or a parent who has that intimate connection with you, or is it a more casual acquaintance who's you know whose role is not to say something like that? And you're you need to do two things. You need to first of all remind yourself that they're saying that out of concern, and then to be able to come back with a very good response that will help reassure them that yes, you are managing your illness and that you are being responsible in managing your illness, and that they can trust you to do that, and that if the person who is asking this question is an adult who then and is not a child, then that should be the end of the conversation. If it's a child, then there's more negotiation that needs to go on, if it's a child or a teenager. But clearly, just to reassure them that in fact you are um, uh, not ignoring your signs and symptoms, which, albeit, there are times when the person with the illness is the last one to recognize the symptoms in themselves, but to reassure your family that you are managing your illness.
Okay, great. Thank you for that answer. The next question. My bipolar family member threatened suicide in front of me, and now I feel traumatized. Is this normal?
Very much. It's a very difficult experience to go through. It's terrifying for you to fear the loss of a loved one like that. Sometimes an individual, whether they have bipolar disorder or another diagnosis within the mental illness, categories, sometimes an individual might throw out a threat to a family member, and your response is very important in that moment, because then they see your response and they learn something through that. Sometimes they do it for the response. Sometimes it's because they're truly in a desperate situation and truly feel suicidal. And that, I would say, would be, more or less more of the time. I would argue that a person who's a caregiver also needs support. The support of either your family doctor or a family therapist, and someone to go to in moments like that, to be able to talk through the difficulty of that moment, and try to understand it and to come to terms with it, and to not live in fear, a continuous fear of that, potential tragedy occurring. It's a risk factor of the illness, yes, but you also need to care for yourself and that's a very important, piece of the puzzle, of course. So I would recommend that you find somebody. Sometimes you find a clergyman can provide that role. So whoever it is that's available to you, to kind of sit down and help you through getting through that moment, I think would be advisable.
Okay, great. Thank you for that answer. The next question, how can I discover the difference between enabling and support?
As a family member, that's a very good question, because of course one wants to be supportive and not enabling dysfunctional behaviors in a family member. Oftentimes it's not easy to tease out the difference between those, because sometimes there's a fine line that separates the two. It's a gradation, and again, that might be a situation. It's difficult to throw out a very simplified answer. That would not be fair to you, but there might be, and that might be a situation where speaking with a mental health professional might give you that answer that you're looking for.
Okay, great. Thank you for that answer. Let's see. Okay, the next question, how do you answer when your family member with bipolar disorder says, I'm never going to be normal or successful at anything. Why should I go on living? I take all of my medications and go to therapy and nothing works. It's hopeless.
That's a really hard one, because the person truly believes that to be so, and feelings of hopelessness are very common, particularly when they're during the depressed phase. The best way to approach that is to come up with concrete evidence in their lives to support their prior successes and achievements, and to match that up with their future goals and their skills. That perhaps it was an academic achievement that they want, or a sporting event, or they're good at some particular at painting, or some particular other skill, cooking, baking, whatever it is. You just have to help them come up with the list. There's a very good exercise in the first book I wrote. The book is called Managing Your Depression, which is called Evidence for and Against. And you sit down and on a piece of paper, you draw a line down the middle of the piece of paper, and you think of whatever the particular problem is. If it's a dysfunctional thought, the feelings of hopelessness in this case would apply. And in one column, you write down the evidence in your life that supports that thought. In the other column, you write down the evidence in your life that goes against that thought. But it's the person who has to do that. You, the supporting family member, can't tell them that. You can help remind them, but you can't originate the ideas, because it won't be as effective. And it can, you can do it over the course of a week or two. You don't have to just sit down and do it all at once. Make it a running list, and do it as a slow thing. But it can be something that's quite effective, because they can't argue against their own past success.
Absolutely, that's a great answer. Um, One more question. How
Okay.
do you approach your loved one when they're paranoid? When my partner is hypomanic, he sometimes gets very paranoid about my male friends, and it causes friction between us. I try to reassure him and show him that there is nothing else going on, and he can see that there is nothing there. But sometimes the thought and feeling get the better of him and behaves in ways that he wouldn't when he is not in an episode. Staying calm and continuing to reinforce the fact that there's nothing going on seems to help, but is there more that I could be doing?
Well, it sounds like you're doing a lot of what's required. A lot of the work that he has to do may also come in his work with a mental health professional. So I would recommend that he receive that care in addition to what you're already doing, because it sounds like you're already doing the most there.
Yes, thank you for that. And I think that's all the time we have for questions today. I want to thank everyone for joining us today in this webinar. And just a reminder, the webinar is being recorded and will be available on our website at ibpf.org. I want to thank Dr. Noonan again for being with us and sharing with us this valuable information. Thank you, everyone, and we'll see you next time. Take care.
And
Bye-bye.
and I thank you.